Welcome. I'm Shannon Oliver O'Neill, licensed independent clinical social worker and ASEC certified sex therapist. I'm the director of the Rhode Island office at the Center for Growth. This is a presentation on treatment protocol for erectile disorder of psychosomatic origin. This is something I've seen a lot of since starting at the Center for Growth about 8 years ago. I think it's really wonderful work. As I said, the clients are really motivated. You can see a lot of movement in a relatively brief amount of time. And so even if it's something you're not familiar with yet, I really encourage you to consider working with these clients for these reasons. And we'll go over today a treatment protocol rooted in mindfulness that I use. Treatment overview. We're looking at 5 steps in treating erectile disorder. And if the case is not complex, by which I mean there are physiological causes or some kind of severe comorbidity, we can expect to see movement within 4 to 6 months of weekly sessions. The 5 steps that we're looking at are 1, assessing etiology. What are the causes? Talk therapy is indicated if it's psychosomatic in origin. So we want to make sure that is the case. And if that is the case, we want to get a better understanding of what psychological issues are at play. And second, we really want to educate our clients about what is happening, what physiologically and psychologically are they experiencing, and what skills will they need to meet their goals. When clients come in for any specific behavioral issue, it's super important to orient them to treatment in order to increase their engagement. If we over-focus on skills without looking at psychological causes, or if we over-focus on causes without skills, we won't see change. So educating the client about what they're experiencing and what treatment is going to look like is really crucial to seeing change. Third step, we want to build intero and exteroception skills. By that, I mean interoception, the ability to sense sensation inside the body, and exteroception, the ability to sense sensation on the outside of the body. And we do that through mindfulness. As with many sexual function issues, erectile disorder is often the product of dissociation and lack of awareness of the body. That can be caused for lots of reasons. Clients are ultimately focusing on thoughts versus sensations during sex. Those thoughts could be fantasy, they could be fears, they could be criticisms of their self or their partner. We really want to build up those intero and exteroception skills. The 4th step we're going to do in treatment is we're going to build anxiety and emotional regulation skills through mindfulness and cognitive work. This allows clients to tune into sensation even as distressing thoughts and feelings arise. Typically with erectile disorder, once distressing thoughts and feelings arise, it can be really hard for clients to avoid that tendency to dissociate. So we're building up those skills as part of treatment. The last but optional step is implementing these tools in a partnered setting. Some of your clients may not have a partner, or their partnership may not be ready for sexual function work. For those that are ready, this can be a really important piece of developing and deepening these skills. Generally, with sexual function issues, we're doing a lot of exposure work. We're starting with the fewest number of activating experiences and working our way up to the highest challenge level. And so with erectile disorder, this often looks like starting with individual interventions and working our way up to partnered work. As I mentioned at the top, generally treatment is pretty brief, 4 to 6 months. This may vary depending on comorbidity. Things we can commonly see and expect to see are trauma, obsessive compulsive disorder, compulsive behaviors, gender dysphoria, and any of these can lengthen the type of treatment needed and may need to involve collaboration of care with other types of providers. That's an overview of all the stuff we'll be covering today. First, we're going to talk about assessing for etiology or causes. The first thing we want to know is if this is a psychosomatic or physiological issue. Therapy can assist in cases that are psychosomatic or where there is a hypertonic pelvic floor. just because of the interplay between muscle contraction and tone and cognitive emotional function. But other physiological causes really need medical intervention and assessment. Sometimes a client will have gone to a doctor before they come to see us, but a lot of times they don't. It's really important that we ask some questions in that first session to determine whether or not we want to make a referral to a urologist or some other kind of medical specialist. I put a list here of some useful assessment questions. These just follow the DSM-5 criteria for erectile disorder. The first question we're asking is, do they have difficulty obtaining or maintaining erections, and how do they feel about it? If there's no distress, likely they're not going to seek you out if there's no distress, but certainly if there's no distress, it does not qualify as a disorder. Is this lifelong or acquired? When did the trouble begin? Is it situational or generalized? Here, it's important to get really specific. Can they get erections in some contexts? Maybe they wake up with erections or get them while they're sleeping, or they're able to get them on their own, or with some partners, but not all, or during specific activities with a partner, but not all activities. There really can be a great amount of variation. It's really important to get that information so we can learn what may be underlying all of this. We also want to know about any chronic or acute health conditions or any other changes in sensation, by which I mean not just having difficulty experiencing pleasurable sensation in their penis, but have they noticed any changes in their ability to sense sensation in any other parts of their body? Because that may indicate some kind of neurological issue. Are they taking medications, and have these changed since the issues with erections began? Are they using any substances, and have they noticed any impact on erections? All of these are a great first step in determining whether or not there may be a physiological issue. All of these things that are towards the bottom, right? The health conditions, changes in sensation, changes in medication, changes in substance, those would all be signs that we want to get them checked out by a doctor. If none of those things are present, or if they're present but a doctor indicates that they think talk therapy would still be useful, then we want to get into assessing psychological causes. Here's our two broad areas. One, we want to get at specific expectations, beliefs, and values towards sex. We get into questions about what is healthy and unhealthy sex, what is successful and unsuccessful sex. And then we get into the mental and emotional patterns around specific sexual behaviors. It's very important to get very granular, very concrete. Oftentimes, for many clients, if left to their own devices, they'll be vague when talking about sex, just because it's not something we commonly do in our society. It's not something we have a lot of practice doing. You might ask a question about how do they feel before sex. They might tell you, oh, I feel fine, or I feel anxious, but we'll miss out on a lot of really rich information if we don't get much more specific. So I've got some examples of more specific questions, right? We want to know how often they're thinking about erections. Is it just like in the lead up to sex? Is it something that's happening all the time? Is it weekly, daily, constantly? If that's happening, that may indicate that there may be some OCD related issues at play. We also want to know when they're thinking about erections, what are they feeling? What do they do in response to those thoughts and feelings? We want to know what they're thinking and feeling when they think about initiating sex, when they initiate sex, when they're engaged in sexual contact and afterwards. And with all of these things, we also want to know, what are they doing to initiate sex? What are they doing when they're having sexual contact? What are they doing after they have sex? Are they staying in bed with their partner and talking about it? Are they isolating and withdrawing because they're having a lot of difficult feelings? We want to know all of that stuff. We want to keep in mind that it's really common to see comorbidity with erectile disorder and anxiety, trauma, obsessive compulsive disorder, compulsive sexual behavior, depression, gender dysphoria, and body dysmorphic disorder. So we just want to keep our eyes open as we're assessing to see if we see any symptoms of those issues. So I talk a little bit about how those comorbidities can impact erections. This is bird's eye view. I think it can be helpful as you orient yourself to prepare to do treatment, just to have at least a little bit of an eye on how this might impact the client. So with depression and anxiety, we've got, of course, the impact on mood, difficulty being present versus future or external focus, difficulty with regulation. Trauma, we often see this have a big impact on expectations, beliefs, and attitudes towards sex, even if the trauma was not sexual in nature. This can impact the ability to feel safe, to regulate, to be present. OCD, it can be really common to see obsessions about the relationship or about sexual behavior that can then impede erections and the ability to be present, and can really have a big impact on the meaning the client makes of the fact that they're having trouble with erections. Compulsive sexual behavior, regardless of the type of compulsive sexual behavior, this can lead to dissociative sexual practices that make it hard to be present during sex, and can also make it difficult to feel aroused outside of those compulsive or ritualized behaviors. It's important to keep an eye out for and understand what those behaviors might be. For gender dysphoria, client may be actively triggered by engaging with their penis. This can lead to dissociation, difficulty being present. With body dysmorphic disorder, it can be common for folks who are experiencing this to see obsessions about their penis specifically, or their appearance more generally during sex. Also sometimes see like BD by proxy, where the client will get really obsessive and think quite a lot about their partner's appearance during sex, all of which, of course, can impede the ability to be present and therefore to have erections. Let's do a little bit of a practice applying this. Do we think sex therapy would be indicated here? Is this a largely psychosomatic or physiological issue? For client one, we've got a person who can have erections while masturbating, though they may lose the erection before experiencing the orgasm. They're rarely able to get erections with a partner. No chronic or acute physical conditions, and no medication. What do we think about this client? Psychosomatic or physiological? And I can't see any of you, so you'll just have to speak up.
It looks like client one is psychosomatic and client two might be physiological.
Okay, and what's your reasoning for that?
For client one, able to have erections while masturbating, but then it's issue with the partner. And then with client two, it's not just an erection issue. There's low desire, there's low mood, there's also fatigue and weight gain. So things that two kind of more going on.
That's exactly right. With client one, there may be a host of psychological factors that impact client's ability to get erections with a partner and to get erections as they approach orgasm, or to maintain that erection. With client two, we're seeing a lot of things that may overlap with low testosterone, a drop in testosterone, and potentially some other physiological issues as well. It would be important to make a referral to a physician, client number two. Generally, it's nice to have your client go to a doctor. You never know what you might miss. Getting that second opinion is always good. We've completed assessment. We've determined client is an appropriate case for sex therapy. We move on to step two, which is educating and orienting the client to treatment. This is a really important step if we want to increase client engagement and hope. Clients need some sense of hope in order to fully commit to treatment. In order to do that, they need to understand what it is they're experiencing, and what it is we're proposing will improve their ability to meet their goals. First and foremost, it's helpful to be able to explain the physical processes that lead to erections and that may be experiencing difficulty if erections aren't happening. I'm doing big overview here. stimuli that could be physical, like being touched, that could be visual, seeing something stimulating, that could be cognitive, having thoughts or fantasies about sex, or emotional, whatever they may be. Those stimuli cause the brain to release neurotransmitters, which then increase blood flow to the penis. The penis is made up of corpora cavernosa and corpus spongiosum. So these big, kind of like hollow sponge-like structures can fill up or empty of blood. When they're less full, the penis is more flaccid. When they're more full, the penis is more rigid. Something that's particularly relevant to clients is the role of the pelvic floor. The pelvic floor is a collection of muscles that's like a little basket hanging between our hips that holds in all of our reproductive organs, helps us with movement. More specifically, in this case, where it's relevant is that the pelvic floor muscle does form a ring around the base of the penis. And so it plays a big role in allowing blood to flow in and out. If the pelvic floor is engaged and there's already blood in the penis, then it can help maintain that erection. If the pelvic floor is engaged before there's blood in the penis, blood's not going to be able to get in and erections will be more difficult. I think it can be particularly helpful to talk to clients here about the interplay of the physical and the psychological. We all carry tension in different ways. I know for myself, I tend to clench my jaw, maybe my shoulders clench up. For a lot of people, there's over-engagement in that pelvic floor. That can lead to either just engaging it at the wrong time and cutting off that blood flow when you really like it to be there, or it can even lead to chronic overtone in the pelvic floor to the point where the client may need physical therapy to help them release and relax that muscle. It can be helpful for clients to hear all of this from us. Many clients know that blood flow is involved in erections, but aren't completely sure about why that may or may not be an issue, or the role of the pelvic floor. So being able to share that with them can help clients visualize what it is that we're working on. Other important things to educate them on are the function of intero and exteroception. So interoception, that ability to sense internally, is really important here with that pelvic floor, right? If we can build that ability to tell, is my pelvic floor engaged? Is it released? Client's going to have some more agency and control over that. And exteroception, can I be aware of sensation in my body and in my penis specifically, so I can be present during sexual activity? You can talk to the client about the impact of mood, not just anxiety and obsessions, on these things. Also, the habituation, the impact of habituation on partnered or solo activities. I mentioned this a bit with the compulsive sexual behavior, but just if we create a lot of rigidity around what are the environments in which you're able to feel arousal and tune into your body, it may be really hard to access those things when you are engaged in activity that's not one of those rigid or ritualized things. If we boil this all down, the overarching goal is to teach clients how to be present versus dissociated during sex. And that's what we'll just keep coming back to over and over again through a variety of different exercises. For steps 3 and 4, like teaching interoception, exteroception, and emotional regulation, in my treatment, I blend them all together. They're all touched on through the range of both individual and partnered activities. So what I'll do now is I'll talk you through first the individual and then later the partnered activities. We're looking at generally skills to build the ability to sense sensation externally and internally, to be able to notice and diffuse from emotions and negative cognitions, to accept any emotions and sensations that arise. It can be really common in folks with erectile disorder. There can be a big emotional reaction to either having an erection or not having one, right? They can get really invested in, oh, I'm feeling pleasure. What do I need to do to make sure I continue to feel pleasure so I can keep this erection? Or I'm not feeling as pleasurable. I'm having some panic because what does that mean for my erection? We're practicing this ability to observe and accept any emotions, any sensation that arise, instead of pursuing and over-focusing on particular ones. For solo exercises, tools that I use with clients to meet these goals are body scans, pelvic floor engagement, or essentially Kegels. mindful masturbation, and mindful masturbation with start and stop elements. And I've listed these in the order of least to most exposure. We start with body scans, which are not particularly erotic at all, and go all the way to mindful masturbation, where you're actually engaging with the penis in an erotic way. We're exposing them to potentially losing erections through that intentional pausing during the exercise itself. I talk a little bit for each of these about what are the specific skills that the client is learning with each of these exercises. It's really important that we're able to do that throughout the work, to explain to the client why we're having them do this thing. For many folks who seek out therapy for erectile dysfunction, they have not done therapy before. Just making sure they're oriented to what we're doing and why throughout treatment can really have a positive impact on outcomes. With body scans, we're teaching them how to breathe. We're teaching them how to practice noticing thoughts and emotions, and how to pay attention to sensation throughout the body. I'll usually have clients do full body scans with some intentional attention on the groin and pelvic floor, just to practice that. Most importantly, we're doing this together in session at least once, because this can be a new skill for a lot of people. So you really want to take some time to do it together, see how it goes, troubleshoot whatever difficulties they're having, and then they're practicing that daily. For pelvic floor exercises, we're building that interoception skill, as well as the intentional ability to engage and disengage. And we're continuing those mindfulness skills we worked on in the previous body scan exercises. So some examples of that can be daily reps of Kegels combined with body scans, or the 10-5-0 engage release exercise. What I mean by that is I'll ask them to engage that muscle as hard as they can, 10 out of 10, then release halfway to 5 out of 10, then release fully to 0 out of 10. This is a pretty difficult exercise, just keeping that level of control, like disengaging to the halfway point. I find that most clients are not able to perfectly do that, but they are able to build a much better awareness of what kind of released, fully engaged feels like. So it's a useful tool for that. Then for mindful masturbation, now we're introducing, okay, can you keep all these skills you've been building while we're also engaging in erotic touch and directly touching the penis? Because that can up the activation for some folks and engage some of those old patterns we're trying to change. Some things that I'll do to help with mindful masturbation, instead of just saying, go out and be mindful while you masturbate, I think it can be really helpful to give some structure. I'll provide sensory focal points. I'll tell them to pay attention to texture, temperature, and tone. If they find that their mind is wandering, come back to one or all three of these sensory focal points. Can you pay attention to what temperature you're feeling with your fingers, what texture you're feeling with your fingers, what muscle tone you can feel with your fingers? I will also often provide specific masturbation techniques or touches. Purpose of that is a few things. One, it can help break habits, it can introduce new sensations, and it can provide safety, and that client's not having to make a lot of choices as they're just starting out trying to figure out how to mindfully engage with this part of their body. Most importantly, through all of this, the client is not using any porn, the client's not using any fantasy, and they're not using any evaluative words. So they might have some thoughts like, oh, this feels good, this doesn't feel that good, this is boring. And their job is just to notice that's happening and then come back to those sensory focal points of temperature, texture, and tone, because we want to get out of that trap of being attached to and pursuing specific sensations. We want to practice accepting all sensations and degrees of erection as they present themselves. Finally, in the individual exercises, we're doing stop-start mindful masturbation. So the purpose of this is to practice intentionally pausing erotic stimulation so that the client has a chance to practice tolerating losing erections. As I mentioned before, this can be pretty distressing for folks with erectile disorder, and we're now helping them practice observing and accepting those feelings versus going down a rabbit pull, trying to do something about them or trying to avoid them. We're maintaining all of the other skills folks have already been working on in terms of sensation, accepting emotion, degrees of erection, and essentially we're doing what they've been doing, right? Mindfully masturbating for 1 minute, pausing for 1 minute, masturbating for 1 minute, pausing for 1 minute. It's important that the client continues the exercise regardless of their degree of arousal. If they have no erection at all, or even if they have an orgasm during the exercise, they're completing the whole thing. Purpose of that being, we really want to reinforce this idea that there's no degree of erection we're pursuing here. They're doing the exercise to practice the skills, not to achieve a certain kind of erection or sexual experience. Usually I'll have them repeat this for 2 to 3 weeks while gradually increasing the time increments. Eventually we're switching to internal versus external cues. So they're stopping and starting based on if they're approaching orgasm, if they're losing an erection, versus that external cue of time passing. All told, all of these individual exercises may take a couple of months, may take longer depending on comorbidity issues. And I'm going to talk a little bit in a second about what we'll do in session. I know this is a lot of information, so I just wanted to pause here, rest your eyes on these cute otters, and did anyone have any questions so far? Okay, great. We'll go into what we do in session. In every session, we're processing the homework. We're looking at how did they think and feel about the homework? What was their focus doing? What did they do when their focus wandered? What sensory focal points were most effective for them? Did they feel aroused? And if so, how did that impact focus, emotion, and thoughts? We're practicing diffusion and all of these other skills in real time in session. So we're paying attention to thoughts and feelings that come up in session and helping clients practice observing and accepting them versus avoiding or engaging with them. We're exploring the roots of difficult thoughts and emotions. We're assessing the thoughts and emotion patterns that occur throughout the week, particularly in relationship to the anticipation of doing homework, masturbating, partnered sex, dating, or sexual relationships. All of that stuff is going to have a big impact on erection. We want to capture that and help the client think through how these things are related. It's really key that we take a significant amount of time to go over the next week's homework step by step. Just like I said with the body scan, you really want to, for the mindful masturbation, you're not having them do that in session, but you are going over it verbally step by step so that you can get a clear idea where the client may be hesitating, what they anticipate might be difficult, and the two of you can troubleshoot that together. We want to explicitly identify the skills the client's going to practice by doing these exercises to help with that orientation to treatment. We want to reflect with the client on what skills they've developed so far and help them see their progress or barriers to progress. Of course, we want to treat any other comorbid symptoms that I've mentioned before that might be impacting erections. Once they've completed that series of individual exercises, we want to assess if they're ready for partnered exercises. And the way that we can assess for that is just seeing, are they able to maintain focus on sensation during the exercises? Are they able to diffuse from and accept any thoughts and feelings that arise? Can they accept whatever arousal is present during the exercises? And then this last one is not something I'm going to share with the client that I'm assessing, because again, we really want them to practice accepting whatever degree of arousal is present. But I'm paying attention to, are they able to obtain and maintain erections during exercises more than half the time? They're going to have skills from all of this that will serve them whether or not they're able to obtain or maintain erections. If they are not getting erections more than half the time and all this other stuff is present, that may indicate that it's time to go back to the drawing board and bring in a medical assessment to see what else is going on if all of these other skills are happening. So assuming all those things are checked off, then we want to think about, okay, is it actually appropriate for the client to move on to partnered activities? If they don't have any sexual partners, of course, we wouldn't move on to partnered exercises. So you might want to talk to them about, do we want to change the focus of treatment? Or do we want to pause until they have a partner to practice tools with? If they are in a partnership, but there's high conflict, we may want to send them to couples therapy first. It would be really hard to do any of these exercises effectively if the relationship itself is under threat or if the client or their partner don't feel safe. Otherwise, it's time to shift into those partnered exercises. This is another chance to ask any questions before we transition into partnered exercises. When we transition to partnered work, there are a few things we want to do before we start the exercises. So first is, just as you would in a treatment review, we're identifying all the skills the client has developed, all the challenges they anticipate during partnered encounters. We're preparing the client to invite their partner to join some sessions. So we want to work with the client to establish what's the goal of having their partner join. What will they share? What won't they share? We want to actually invite the partner to join so they can receive instructions for partnered exercises. It's not necessary. You could have the client relay this themselves, but I think it's much more effective if both of them hear it from you, so both of them can ask you questions instead of the partner asking your client questions they may or may not have the answers to. You explain to the client and the partner the skills they'll develop through these exercises. All of these are all the skills your client's already been working on, plus the ability to do that in the presence of another person. Then we get into the actual exercises themselves. What we're going to have them do is a series of partnered mindful touch exercises. The skills that they're going to get from these exercises are maintaining focus on sensation while adding in variables one at a time. These variables are touching another person, being touched by another person, feeling aroused, potentially witnessing a partner be aroused or unaroused, having their genitals touched, and potentially experiencing penetration if that's a goal for this couple. They want to practice observing and accepting thoughts and feelings that come up while exposed to all of the above, and practice accepting any and all levels of arousal while exposed to all of the above. Here are some general guidelines for the mindful touch partnered exercises. Generally, you're always going to have a toucher and a touched. I avoid using the terms giver and receiver because if you use those terms, it can give the impression that the person who is receiving touch is the focus, and that's not actually the case. We want each person to be focused on sensation, whatever their role is. Throughout all of these exercises, both partners will be naked. Of course, if there's trauma or some other issue that makes that feel like too high exposure to start, you can scaffold your exercises so that you are starting with a lower degree of exposure, and you can talk to your clients about that. Toucher is touching for their interest and pleasure, not to provide an experience to their partner. Toucher should be paying attention to those same sensory anchors of texture, temperature, and tone, while the touched person will practice observing sensation without assigning value, i.e., this is good, this is bad, this is hot, this is boring. We're practicing that same skill. Can I accept all sensations that arise? Of course, if the touched person is ticklish or emotionally activated, we ask them to see if they can observe that for about 30 seconds, and then if it's still uncomfortable, they can move their partner's hand. If touch is painful, they should move partner's hand immediately. I ask that no one talks during the exercises. Instrumental music is okay, again, just to help with that focus on your own sensory experience. I ask that there's no sex immediately after the exercise to avoid building the expectation that the homework leads to sex, because that can reinforce some of those old problematic patterns. And unless explicitly stated otherwise, all phases are hands only. We're not using other body parts to touch. And most importantly, exercise should continue regardless of the level of arousal of participants. If someone is completely flaccid or someone has an orgasm, the exercise is continuing until the time is up. Because again, we're teaching that we're not pursuing a particular sensory experience, we're practicing accepting all levels of arousal, whatever they may be. So then I'm listing out all these different phases. The important thing, like overview, is that we're scaffolding again from least activating to most activating. We start with full body, no genitals, no erogenous zones, and moving up to whatever the preferred sexual activity is that the partners so far have been having trouble with. In this version, I wrote it out as penetrative penis and vagina sex, but it could be penetrative anal sex, it could be oral sex, right? It could be lots of things, just depending on the stated goals of your clients up front and what's been difficult for them so far. Using that scaffolding, we've got full body, no erogenous zones, then we've got full body, including erogenous zones, then we've got exploration of genitals in particular, then we've got full body touching with some feedback, we've got mutual touching, we've got genital to genital exploration, we've got insertion without movement if they're working towards vaginal penetration, we've got insertion with movement, and we've got insertion with pauses. Purpose of all of these, again, whether you're working towards vaginal penetration or not, is helping the clients practice engaging in their preferred sexual activity with intentional pauses. So there are opportunities for them to practice engaging in this activity while most likely losing an erection, so they can build distress tolerance around that. This last little bit is just what you're actually doing in sessions. It's pretty much exactly the same as in solo sessions. We're spending a fair amount of time on the homework, some experiential stuff, some like symptom management, and then prepping for the next week's homework. The last thing you'll do is, once they've been able to use all of these skills successfully, you'll help them come up with a maintenance plan for what tools your client wants to use individually and as a partner in case symptoms show up again, because they might. And that is that. Yeah, this is a checklist for when the client knows they're ready to change phases or not. So I will leave it there. I think it's also important to touch on common issues. So pacing, it's really important to accurately assess clients' ability to perceive sensation, use all these tools, and then move at their pace. If you move faster than they can go, they'll not build the skills, even if they tell you they're doing good. If you move slower, they may not see results and they'll drop from treatment. I've talked a lot about orienting the client to treatment and just how important that is in building trust and promoting engagement. It's really important we pay attention to comorbid conditions. They can all require additional interventions and potential treatment by other types of providers. And then high conflict in partnership. Client will not be able to utilize these skills if relationship or the client themselves is under threat. Those are my common issues. A lot of content that we've covered today. I think this is such a rich area for treatment. And I hope that if this is something you're even mildly interested in, that you take a chance and try it out, because I really do think it's very rewarding both for the clinician and the client. Okay.
I would one more maybe. Oftentimes, I know when I work with some of my clients, I find it sometimes helpful to have the partner at some point maybe come as part of a conjoint session. Can you speak to that and what you do and how you maybe present that to the client as an option?
The question was like, how do we incorporate client's partner into session? Once I think the client is ready for partnered activities, that is the frame through which I am incorporating the partner. I might incorporate the partner earlier if there is some kind of conflict within the relationship that is impacting the client's ability to even do the solo exercises or to manage some of those other symptoms that we talked about. If we're just talking about incorporating the partner for the purpose of partnered exercises, I'm having them actually join quite often. I'm having them join for the first half of every session. We may be meeting less often at that point. We may be meeting every other week instead of weekly, but I find that's really useful to have the two of them process those exercises together and then to really go into depth explaining what they're going to tackle next.
I have a question coming off Tanya's.
Yeah.
So you said when you start incorporating the partner in for partnered exercises and stuff, you're having them come at the beginning, the beginning half of almost every session at that point
Mhm.
to process it. What if they also have a concurrent couples therapist? Is the work that they're doing in couples therapy different than the work you're doing with them?
The question was, what if the client is also in couples therapy? You'd want to get permission to coordinate care with that couples therapist to learn a little bit more about what their goals for treatment are. Your scope is actually quite narrow in that situation, and that you're truly just focusing on the homework itself. And likely, if they're in couples therapy, there are some like relationship dynamics that are difficult for the two of them. And so you're identifying when those pop up and you are sending them right back to couples therapy to work through that.
Can you talk a little bit about how to approach sessions when the client has not done their homework or are just not willing to process thoughts and emotions on a deeper level?
So the question was, what if you have a client that's not doing homework or does not have a great degree of insight around thoughts and feelings? I think in those cases, that can be really frustrating for both of you. And I think that's important to remember too, that likely the client is also having a hard time in therapy. I might do some exploration of how the client is feeling leading up to, before, and during and after session, what their literal experience of therapy is. I might explore with them what they think about the homework exercises and what's happening as they think about preparing to do them. And I'd be looking for, what are the other symptoms this client is experiencing that may be impacting, there may be interplay with the homework and with the goals of having an erection. It's hard for me to get more detailed than that without asking you more questions about your specific client, but hopefully that's a path at least to walk towards.
Thank you. This was absolutely amazing. I will also stop the video, but absolutely fabulous. I'm so excited.
Great. Have a great rest of your day, everybody.